My research focused on evaluating the newly added and considered cardiovascular genes on the ACMG version 3 secondary findings list for Geisinger's MyCode. Geisinger's MyCode Community Health Initiative strives to understand population-level genomics by pairing patient health records with genomic data. Medically relevant results are returned to participants to detect diseases earlier and establish intervention and prevention plans. Genes that are returned are based on the recommendations put forth by the ACMG's secondary findings list, and these genes are considered clinically actionable and place a limited burden on patients and laboratories. Therefore, it's important to evaluate these secondary findings genes because the MyCode participants will directly receive results about these genes. The most recent version of this list was published in May of 2021, and the breakdown of the genes and their associated disorders are shown in Figure 2. And while the ACMG cautions the use of the secondary findings list for population screening, they recognize the need for more research endeavors such as MyCode in this area. The cardio genes of interest for my research are highlighted in the teal boxes in Figure 3, and the 4 new genes are Cas-Q2, TRDN, FLNC, and TTN, as you can see in bold. The genes that were considered for this newest version but were not added are labeled as the watchlist genes. And the overall goal of my project was to evaluate these new genes and watchlist genes to see if it would be warranted to include them in the MyCode population screening. Various public resources were used to collect information pertaining to gene disease validity, actionability, variants, and other estimates, and shown in Figure 4 is the curation evidence collected on the genes of interest. FLNC, Cas-Q2, TRDN, and RBM20 have evidence that is comparable to the evidence supporting genes associated with the same disorders that are already included in MyCode. RBM20 is a watchlist gene that has a significant amount of evidence supporting the early disease progression and aggressive disease development. Therefore, these 4 genes should be considered for MyCode. Conversely, TTN does not have strong enough evidence compared to the other already incorporated DCM genes in MyCode, and this is based on variant interpretation difficulties, low penetrance, and variable expressivity, and these 3 factors collectively place a high burden with low benefits on the individual. Therefore, further evaluations need to be made before disclosing results. The other watchlist genes had large variations in the disease presentation and didn't have well-established genotype-phenotype relationships. So although additional research and evidence are needed before incorporating these genes into MyCode, I hope that this is a step in the forward direction for evaluating these version 3 genes.